Hi, everybody. My name is Mark Stebbin. I'm the president of IUSTI Canada. And we have the pleasure today to have with us a great lecturer, Dr. Jean-Pierre Routsy. And he will be talking about HIV cascade of care, integrated lessons learned from COVID-19 pandemic. Our objective is to compare a cascade of care endpoints before the COVID pandemic to those of today, understand the weaknesses of the cascade of care in Canada, review potential upgrade of the cascade of HIV care, and to appreciate conditions that would insulate the cascade of HIV care against potential future challenges. So to discuss HIV cascade of care, we have Dr. Jean-Pierre Routsy, who is the clinical director of the chronic viral illness service at the Louis Lowenstein Chair in Hematology and Oncology at McGill University. And he's the local co-chair of the 24th International AIDS Conference that will be taking place in Montreal from July 29 to August 2nd in 2022. Jean-Pierre, please.
Thank you very much. I'm very pleased to be here. Thank you, Mark, for this introduction. And I'm glad to speak to you, at least of my vision. And today, of course, is a special day because it is the December 1st, and you know, it's a World AIDS event. And this evening will be a meeting in French in Montreal to thank the pioneer male and female who initially responds to the epidemics of HIV. So it will be a unique celebration 40 years after. And this event will be unique by the community spirit, pioneers, and some being quite old, and also the new generation, the future, and the unmet need of HIV. And one of these needs, the cascade is still a cascade, is not a lake. And that we will discuss the points where there is improvement to be done. So this morning, when I wake up, I read the Francophone journal, Le Devoir, and interestingly, for the first time, 3 family doctors from 3 big HIV and STI clinics in Montreal joined for a common paper to show the importance of primary care management of HIV and STI, and also for the prevention using PrEP. And it's very nice to see a united response from private clinic in Montreal to try to tackle HIV pandemic in organized way. Of course, everything due to COVID, there is a word of yesterday, and since 2 years we have, or we are living in a different type of world, and let's see what the world used to look like. So everyone knows that if we speak about HIV in the recent past, the bulk of the epidemics were far from North America. The bulk was Southern Africa and Russia not doing too well, and South America, and you see the bulk in South Africa. So in a way, HIV was not contagious to everyone and was limited, but still is big, to sexually transmitted, and the blood transmission is generally control worldwide. So that was a kind of first pandemia that we all know. However, if we look back, silence equals death, and 32 years ago, the International AIDS meeting met in Montreal, and this meeting was very unique by the localization in Montreal, but on top of that, by the participation of community groups. And for the first time, to my knowledge, in a medical meeting or in a scientific meeting, people living with HIV jump on the stage, block the convention during 2 hours, showing the importance of community groups that were not invited to participate. They were the patient, and the doctor or the scientist were two different worlds. And because of the pressure of activists, community groups, patients and their family and friends, our world, at least for HIV, changed a lot and much faster than other type of medical specialty. And they also have a political agenda. Mulroney was the first Premier Minister of Canada, and it was also a big political issue to have resources to speak out about HIV, AIDS at that time. And soon after, we understand that like Houdini, that immune escape occur and leading to drug resistance. And one of the world leaders was at McGill, Dr. Mark Weinberg, who transformed and helped us to understand why HIV virus escaped to the drug pressure. And you know, for Houdini, he was killed he was killed due to a McGill student, as you know, because he was on stage and asked to be punched in the belly and to block the punch. But the McGill student was strong enough to break his spleen and die after this spectacular event, and showing that even Houdini was even to escape the most difficult scenario, and we think that some virus can do the same. So we learn a lot about HIV, and we understand a bit late, 10, 15 years after, that the T cell in the blood were not the most important T cell, were in fact T cell in the gut, having the CCR5 and alpha-4 beta-7 marker, so a homing receptor for gut or intestine marker. And this type of gut HIV CD4 can be disappear in 1 week in monkeys, and in human at least in 2 or 3 weeks after acute infection. And this lack of T cell in the gut led to the leaky gut, to the microbial translocation, a second hit that took nearly 20 years to be understood. And the microbiota translocation of LPS or even fungus product create a low level of immune activation that may persist even on good HIV treatment. And we will see the importance for also COVID, the immune system without medication, the immune fight slow down. There is a type of compromise with not an excellent term called exhaust immune system. It's better to say hypofunction, because it's a deal between the host and the invader to don't attack too much, it can stay, and we don't self-destroy by hypercytokinic syndrome. So we have to see the exhaustion, learn, and it's more clear with COVID, that too much fight kills the host without clearing the microbes. So here, the exhaustion can be a deal to tolerate, and instead of dying of cytokine syndrome in 3 weeks, you die 12 years after by HIV. And then the virus mutate very fast in few days and weeks after the CTL pressure or monotherapy with initial HIV drugs. And you can see HIV drugs started with zidovudine, then 3TC discovered at McGill were allowed to do a B therapy that was able to last longer, maybe 1 year, but still a mutation, immune escape occur. And it is only with the protease inhibitors that we were able to discover the importance of triple therapy with a large genetic barrier that can be given mainly by Sustiva or lopinavir as a protease inhibitor. And then we enter in a more chronic phase and a more manageable disease with much, much less death. So we learned a lot, but we didn't develop any vaccine, and it's still a catastrophe that no HIV vaccine exists. Conversely, the technology and the discovery of antiviral as blossoming, and we have different class or site to attack. And if you attack at least on 2 different sites with the new technology or new medication, you can block the virus without resistance, which is fantastic. So what we lost in the failure of vaccine, we can use what I call now a pharmaceutical vaccine, mean we can treat people, and we have the PrEP to avoid infection, and now PrEP start to be parenteral or intramuscular or sub-Q, and ongoing research of PrEP can be 1 injection every 6 months, so as long as the COVID vaccine works. So I think we learn a lot on medication and nearly zero on vaccine success. And this slide from Anthony Fauci, we are so good with the medication for HIV that we can use as a post-exposition prophylaxis. If you have a sex contact or get prick at the hospital, you can take medication for 4 weeks and you won't be infected if you take in 48 hours. Mother to child fully works with HIV for the mother. So we can use the treatment as a prevention. And now we expand the pre-exposure prophylaxis. So it's fantastic to see that only, which is good, but no vaccine, but by pharmacology, we can block and prevent an infection. So on this slide taken from Bruma Blenner from McGill, a former collaborator, very close collaborator to Mark Weinberg, you can see on this slide where we are today. We can use the medication for prevention, for prophylaxis, to treat, and we can give a triple therapy as it used to be, or we can switch to now to B therapy, and we have very good success. And now B therapy can be done without integras also, offering a larger spectrum of therapeutic intervention, and soon a long-acting, once a week, once every 2 months, once every 6 months therapy are started, and also for prevention with injectable or doravirine vaginal ring. So the world is changing, and HIV is much more controllable. So I was invited to speak to you about the cascade. So you know the AIDS target was proposed with initially the 90% of should be diagnosed, should be on treatment, should be suppressed. And some authors push to say even should be a good quality of life. So you need all these steps to block your epidemic and to have the best objective for a country or for a region. And these targets are hard to achieve. And when you achieve, including under COVID, are hard to maintain, including the last 2 years with the COVID. So let's have a deeper view on that. So we are facing a new virus with a new pandemia, and what can be the positive learning from the pandemia on top of all the negative observation we can obviously facing, and we already know. So it's a RNA virus, different shape from HIV, more spikes than HIV. And the spike are very important because they enter to the receptor in the lung, and all the vaccine, as you know, are developed at this part, but this part, as you all know, is very variable, and then mutants exist. So we want also, because it's a kind of special day, December 1st, remember when in Wuhan the disease started, one ophthalmologist got infected himself, tried to raise public information, the government, the hospital, the police was sent, and finally he died of COVID at the age of 35 years, and he helped the world to wake up and to fight back this new epidemic that was just shut down or closed locally in Wuhan. So conversely to HIV, it's fascinating to compare the map I show you and this one. Developing country, of course, having more flight and travel and exchange, were the first to develop this new infection, conversely to Africa, where probably less travel occurred, and therefore, at least at the beginning, it was a disease of developing country, so the opposite of HIV epidemics, and that have also very important dynamics of response, and of course, the ethical problem to deliver vaccine or prevention strategy worldwide. And, you know, we have to dress, to have a mask, to have a difference. So that's also a change our life, our daily life in the hospital. And probably we will have to go back to this stage. So big news and big leader are on this slide. At the International AIDS Society meeting this summer in Berlin, in fact, it was at home or in your office, Anthony Fauci has a very strong statement and remind us we are the only generation ever in history to be dealing with two pandemics simultaneously. And also very important statement from him, common enemy is the virus, not the people. And that's very important because of the behavior and social issue surrounding both HIV in a different way and also the anti-vax response in many countries. So what we learned from COVID that can be given back to HIV, of course, is very different in a sense. It's an acute infection, not very chronic, or when it starts to be chronic, you may be very sick and you may die. So in a way, in 2 months, you know if you cure or if you die. And in between, you can be sick longer, but you either die or cure, which is totally different from HIV, where only 2 or 4 people has been cured, as we will see very soon. So this virus is mainly in the mucosa, not much in the blood, and generally there is a peak. PCR can become negative, and surprisingly, when people are very sick in the hospital, their PCR is no longer positive, and they may die of a COVID or a post-COVID syndrome, which is very hard to understand, and clinically, you don't see the causing agent, and the patient is more sick after 4 weeks than when he came with a positive PCR, which is still a big debate. And of course, it's a few percentage of the population, but that's the one we are dealing with. And you have different organ damage. So the big thing that we pay a lot of price is this virus is not really transmissible or less by hand, by contact, but by the air. And that was the first evidence that nobody looked at, including our government and many infectious diseases in Montreal, not looking at very good data from China. And in this restaurant, it was one family, and you can see that they didn't touch each other. It was just by the air conditioning, and the virus was spread more than 2 meters away from the A1, from the source person during the time of lunch in a Chinese restaurant in China. So because of that, you know, some infectious disease in province of Quebec said, don't put a mask, even at McGill. One resident told me, you use a mask that should be better used by a COVID person than by you. So it was a very difficult time, and I was right and many were wrong. But the big thing is that conversely to HIV, when primo infection, where people are generally symptomatic, you are in hypertransmission. COVID can be totally asymptomatic, and you can still transmit the virus. And that was just a few months ago. And of course, the wearing a mask was a big issue. And you remember the history of anti-mask policy, which is politically very important in US, in Canada, and even in Europe and Caribbean. So it's a fast turning disease. So PCR is very short. Then you have the antibody detection. But surprisingly and sadly, even in natural history, the antibody don't last. So if the natural infection, which is always better to have than a vaccine, if you survive the infection with no sequela, you can see that is not very immunogenic, as in natural infection, antibody decrease. So it can foretell us that a vaccine that is a mimicry of the infection may also vanish, because real infection antibody response at least vanish. Sometimes you can argue it's a T cell response, and sometimes low antibody are still protecting. So surprisingly also, we learned that COVID, it's a viral infection, but you die of a host response fight. So it's not really the virus that kill you, but your defense, yourself that overshoot the enemy, and then you kill yourself like in sepsis. So it's the host over-inflammation that may be worse than the virus. And to improve, you have to give dexamethasone or anti-IL-6, anti-IL-1, all the anti-inflammatory medication. And surprisingly, once again, people kill themselves more than COVID kills the people. So knowledge can come from 2013. Here, a nice concept and review of sepsis. So we don't speak about HIV, we don't speak about COVID, but you can see that someone who got a sepsis go to ICU, he had a hyper-inflammatory response, innate response, and he can, with help of antibiotics, often improve and recover. And you can see on the green line that the adaptive, so the immune system of T cell, B cell, in fact decrease, where the innate immediate response with macrophage, natural killer, white cell respond immediately. You have an increase of response, and then you persist up to 1 year with inflammatory level higher than baseline. And the same thing for pneumonia. If you do bronchoalveolar lavage, 1 year after, you still have a higher level than baseline, well, before infection. So the body learns or is afraid and keep a kind of high level. And we know that this high level is not that good, because you create a kind of immunosuppression. And when we speak about severe COVID, it can be due to COVID itself, but it can be due to the super infection with bacteria, lungs or blood. And then you have a secondary immune syndrome, like looking a bit exhaustion of HIV with high PD-1, expression of hypo-exhaustion that lasts more than a year in a bacterial sepsis. So, of course, people who survive the long COVID have sequela, and immediately everyone thought is due to COVID. And now there is a second evaluation that was new, the first paper in December and January from last year. People may last and have a sequela from COVID. So is that the sequela from the virus, from the immune response, or just because we were to ICU, bedridden, septicemia with bacteria? So you have this post-infection syndrome. And many things are characteristic, and more people or evaluation show maybe it can be the mixture of an hyperimmune response to COVID, but also just to be in ICU 1 month and you lose your muscle, to have been infected with bacteria and you have this post-immunity syndrome, and the conjunction of stress, losing your job, having infected your family also. So it's hard to tease out what is really the biological effect of the virus versus the host response, and then the general weakness when you're very sick in any hospital. So one example that led me to think a bit, we had a case report of a patient who had a very mild COVID, who stayed home. He was 57 years of age, he had no past medical history. And then he stayed home, he improved, and he came back to, well, he came for the first time to emergency at McGill and have symptomatic COVID with positive PCR the few days after admission. And he worsened over time, and he did the hyperinflammatory syndrome to the extreme, so the hemophagocytic lymphohistiocytosis syndrome, where the macrophage eat everything around, including lymphocyte, including red cell, as you can see on this figure. And published this week as a hypothesis in the New England Journal of Medicine, maybe when you develop, or certain people, of course, it's a fraction of people who are very sick, you develop antibody. But over time, antibody may elicit an antibody. If it is a mirror image of the antigen, and then you have another antibody that attacks the antibody, you have a double image mirror, and therefore it looks like the virus structure. And you may have this hyperinflammatory response in some patients with vaccine, even RNA with myocarditis, and one case of hemangiophagocytosis, and the second case we send for publication. So it can be triggered by the disease and by the vaccine, that is the mimicry of the disease, and the antibody may have an anti-antibody, so double mirror image. You look like the invader, and then you fight back and you become crazy and you kill yourself and not the virus. So that's what we want to prove in these terrible cases we published. So follow the leader, follow Anthony Fauci, and he gave during the Mark Weinberg lecture in April 2021, so 9 months ago, at home, because it was a virtual meeting. And he also talked about the crosstalk between AIDS and COVID, and also the drama of discovering late that asymptomatic COVID can be transmitted. And even worse now, even vaccinated people can transmit. And it shows also the economical health disparity from economical consideration, and also the denialism for HIV, who still exists, and of course for COVID. And as you know, you have to fight a lot on different political agendas. So this week, to have a fresh presentation for you, there is a big philosophical or scientific consideration on unsick COVID people, vaccinated or not, are able to transmit. So what's happened to the immunity of the non-sick? Because initially only data from hospitalized patients were studied, so it was less than 1% of the population, and we learn a lot. But the majority of people can be asymptomatic, and even asymptomatic, they can be reinfected now. So what's happened? What do we know? And that's, to my knowledge, the first review on immunology of low symptomatic COVID infection. And you can see the different level and the different cell involved, and is not very well known for the non-sick because they're hard to reach, and we cannot easily collect blood or do many blood tests or biopsy because they're extremely well, and it's so important for the future of the pandemic of COVID and for the future care of HIV also. So it's obvious, so I won't discuss long, is published by many, including our group. HIV testing in Montreal, they were closed, so obviously testing was not done. They were closed. Social distancing, quarantine, so whatever you do in a quarantine, you're not tested. Linkage to care, of course, we ask people to stay home, to phone us, so we cannot see if it is a syphilis rash. We want diagnostic because of the phone. So it was obvious the linkage to care was not optimal during that time, and many community groups were closed to decrease COVID. So that's easy to understand. ART initiation or continuation, adherence. Some people were afraid to visit a center, to go to the hospital where people were sick, so you can be infected in a hospital because it's a concentrate of COVID people. It was a big limitation for the long acting because they have to be injected every 4 weeks or 8 weeks versus people well known, they can come every 6 months. So the intramuscular who should be easier way was not, and not very used or even more difficult to maintain during COVID. On top, the stress, loss of job, loss of money, loss of income was also a big thing for co-payment and economical and psychological cofactors. So when we compare HIV, will HIV be more sick with COVID or not? And when I present this slide last year, just following the presentation at the national meeting after Anthony Fauci, I say it's not obvious that HIV people are more at risk of COVID because everyone was saying, well, HIV, they obviously immunosuppressed, so they're more at risk of COVID. For myself, it was not that obvious. Maybe higher risk because you have low CD4 when you're sick, so at least below 200, you're sick. Above 200, you're not very sick. So immunosuppression, I think for me, was 200, but it was considered 350 for a hospital. There are more inflammation, even on heart, so they may be more prone to be inflamed. We know they respond less well to vaccines, so after the vaccine access, they may be more at risk. We know they have higher social contacts. We know they may have STIs, so mean inflammation, and they take antibiotics, so they change the microbiota and they disbalance part of their immune system. And majority of people were male with HIV. And we know from China that male are more severely damaged by COVID than female. On the other way, and not many people follow me on that route, and maybe I was right partially. I was saying maybe protease inhibitors, they have a weak in vitro effect on COVID virus, so maybe they can be protective. We will show that not. They have a higher level of interferon, and during the dark age of HIV, always notice that they didn't get much flu disease than the general population, and my idea as a resident at the beginning, because they had a higher interferon level even on heart, so they may have a kind of natural immediate defense for other virus. They smoke, and you know from China and France that smoker may have a less severe COVID, smoker but not COPD. So too much of a thing is a bad thing, but smoker with no COPD, smoke may be a protector because probably you modulate your acyl receptor, so you less response to the outside world due to the smoke, and then you may be less overactive against COVID. At least that's my vision. So immunosuppression may prevent ARDS, and because some observation in cancer or rheumatoid treated people, some data show they were not worse. However, they were worse with Rituxan, that kills B cell, and mainly lymphoma with hematological cancer, where the immune system is involved, were much at risk than regular solid tumor cancer, even on chemo. But still, neutropenia and being sick doesn't help, but the effect was not that big. However, the PCR can be positive in some cancer patients for 2 months instead of 5 days. So initially it was to repurpose medication, and of course HIV medication were selected like lopinavir and ritonavir, and many studies show absence of difference. Tenofovir had a weak protecting effect and it was no effect, and redemsivir has a very modest effect and all that were derived from HIV or directly anti-HIV. So we will see if that was totally wrong or not. So if we compare now the vaccine, everyone asks why there is no vaccine for HIV and why there is at least some partial vaccine for COVID. Easy to answer. No one, with the exception of two, can self-cure HIV. So Mother Nature doesn't have any good way to clear the HIV virus. However, for COVID, 99% of people cure the COVID and only a small fraction get killed by that. So to develop a vaccine, it's a mimicry cure of the disease. So if you go back to Louis Pasteur, you put a part of the virus or bacteria, you make it a bit weaker to not give the disease, and then you are protected. Because Mother Nature do the job, but in HIV it never did, and therefore it's very hard to invent a vaccine because you have to go beyond natural Mother Nature strategy. In COVID, you just amplify something that is provided in the majority of human beings who clear and cure COVID. So that's easy. So we understand and we learn that we have many variants, and it's hard to follow. It used to be Chinese, South Africa, because it was very detrimental for the country. They used alphabetic letter. And then we have the alpha, beta, so everything was clear in my mind. And suddenly, I opened up 1 week ago, it's called Omicron or Omicron variant. I never knew it was a Greek letter. I studied Latin, but not Greek, and I was lost. And then I was invited Monday evening by two professors of literature who study Greek and German, and they say, of course, it's O, because we know omega means the big O, and there is the Omicron, the small o. Okay, so I understand, okay. But why do we skip two letters? Because N is pronounced new in Greek and means the new variant. In English, you cannot distinguish a new variant from the new variant. So they cut this one. And what about the Xi or the E? Yes, but that's the name of the president of China. So we cannot name a virus upon his family name. So then Omicron came, and the next one will be called P, much easy to remember. So that's why it's called Omicron, and it took me a few hours to understand why and why we skip two Greek letters. So remember, omega and the small o, Omicron. So severity of SARS in reinfected. So we spoke about the natural immunity, the herd immunity, and definitively when you got a vaccine and you don't infected and you don't die of it, you are protected, and that's why we can develop a vaccine, because there is a natural protection, and over time the epidemic should disappear with a long time, because the population will be reinfected and immune system will be imperfect, but will be still protective, and you can see a big decrease from different type for people being reinfected, of course, within a short period of time, because we know that 1 or 2 years after, it may not be that protective. So what can we learn from HIV? So of course, people wanted to give Nobel Prize to those who developed the RNA vaccine, and that was also a big decision, fast, and the committee of Nobel Prize said, maybe it's too early, let's give the US Nobel Prize equivalent, the Lasker de Baquet Prize, which is big to these two people, and for Kathleen Karinko, a magnificent success of immigration from Eastern Europe to US, and be able to change the world by her work. So I saw it's a magnifique observation of success and integration of migrants in US. So you can see that was very good news and everyone was happy. However, science doesn't match always with human behavior. You can see from Melbourne, Australia, the anti-vax, and they have to use a gun or at least a gas gun to push back anti-vax people. So human behavior and acceptance of good data from science is not universal, and it's very hard as a population and as a pandemic to have a global acceptance, to have one injection or two injection or three injection. And you can see more recently in French Caribbean, in Guadeloupe, now for the first time they use gun. No one was killed, but they fire with gun to the police, and now they have to send a special elite police to this Caribbean island to try to cool down. And the reason was to oblige healthcare workers to be vaccinated. And the French government 3 days ago removed the obligation from employees of hospital to be vaccinated due to the social riots. So what about Quebec and Europe? And you can see that Canada and US are not too bad, but you can see that Europe is becoming the last month the center of the world epidemics of COVID, despite more than 50% of their population being vaccinated. And you see the increase worse than in July and August. So it's a bit desperate, and people may less trust vaccine potency. Of course, it's the number of cases, not the severity. The severity is decreased by 10, but still to have such a big epidemic, including people being vaccinated, able to transmit, is, I will say, voiceless. It's very hard to explain and a bit disappointing for at least people like me who push a lot for vaccine, and now it looks to be less than we expect. And what about Quebec? And you can see that it's increasing, and also in Ontario, in many places in Canada, and I guess also more recently in US also. So I still read also in the morning by 6 a.m. New York Times every day, and they show me like last week, November 11, that's waning vaccine effectiveness. And effectiveness is a strong word. It's not just antibody decrease, that's to be effective, but effectiveness is how many times you are immune, you are protected from a disease, a reinfection or infection. So the effectiveness really decreased, and it's a growing concern, and that's a bit sad or difficult to explain and to justify our high stimulation on vaccine. And we took the paper from Israel, where they vaccinate early in December, and they were so fast to vaccinate that they put only 3 weeks between the two doses. And after 6 months, the effect vanished, allowing a very discouraging new wave of infection. Is the best vaccinated country, the faster vaccinated country in the world. And that was a bit sad. And you can see when you look at the time to vaccination, more you wait, more you are less protected. And it's depend of the age, but even young people in their prime, over time, you can see it's the opposite. So over time, the effectiveness, the protection decrease after 6 months. So that's a bit sad. And you can see here US data, when you see a military assessment, nearly 2 million military measures, and you can compare the 3 US vaccine. And after the vaccine early December and January, you can see on 2 million people, that's big, and that's big journal science. You can see that the effects of 1- ratio, so the protectiveness, effectiveness decrease with time. So the good news, if you re-inject, so people say that a recall, some people say it's not a recall, it's the full vaccinated. Some vaccine need 3 doses and is not a recall, it's maybe the real vaccine. So we hope it's not a recall, it's just the full vaccinated strategy. And if you revaccinate, you are protected. Surprisingly, 2 weeks after the vaccine. So totally against the idea that antibody are the key player. It's proportional to the antibody level, but to have a response within few days after vaccination means your innate system is at work or push, because it reacts in few hours, not in few weeks as the adaptive system. So there is an immediate protection. So we still don't know if that's the real vaccinate strategy, 3 doses, and that will last longer, or it will follow, as I think, the natural antibody decay, 6 months, 1 year after you become infected, you lose your protection, or at least your antibody. So I don't know, nobody knows. But still, it's a double edge. So, as we say, it was so good for HIV, where vaccine was not at the rendezvous. What about anti-HIV pills that works? And the last 2 weeks in big journal, including Nature, you can see that Merck and Pfizer developed antiviral. They were so good that at mid-study, the ethics committee stopped the study because the efficacy was so obvious. So you stop and you try to get the medication for those in need. And so Pfizer, interesting for HIV people, you have to give a medication boosted by Norvir because the plasma level is not strong enough. So you have to use as a pharmacological agent Norvir, a protease inhibitor that give increased cholesterol. Here is for 5 days, but it's still 30 pills with the vaccine, with the pill from Pfizer, using an anti-HIV medication, mainly for the pharmacologic effect. You prolong your clearance, you decrease your hepatic clearance, and have a higher level of the medication. So it's strange, once again, to use back HIV drug as a booster for a COVID medication. So the crosstalk is a two-way street. It's not just one or the other. It's a two-way street, as science should be. And Merck did something. They put a new name to a new medication according to the god Thor. And I learned that the medication is named not from the god, but from the armor of the god, with is the Mjolnir. And I went to a book feast last week, and I got, maybe you don't see it, but I have my own pendentive for Mjolnir, and the guy was so pleased that I teach him or told him that it was the name of a new medication for COVID, that he gives that free of charge. So thank you. And the medication from Merck is called Molnupiravir because of the armor of the god Thor. And because you speak English, you all know that first day is the day of the god Thor. So for you, is not a very big discovery, the god of the storm. So it's easy for you in English, you knew it. So that's a ribonucleoside, also close to HIV strategy. So you put something in the virus genome and he make error, and then he become crazy, and then he call accumulation of mutation, and they call it a viral error catastrophe, and then the virus is blocked. So will that lead to resistance within 5 days? We don't know, but it's a welcome, and half of the people didn't die, half didn't go to ICU with just 5-day pills, less than the Pfizer strategy. So that's very welcome, and we have another strategy that just vaccine and anti-inflammatory medication. So where we are with the two epidemic, so maybe for COVID, we have to switch from pandemic to endemic. And there is some factor or variable that you know, the acquisition, the secondary transmission rate, and pathogenesis. And then that lead to the concept of epidemics or pandemic going to endemic, means the pathogenicity decrease over time because there is some partial immunity in the host, and then you less sick, and also you reinfected several times. And over time, there is a gentleman agreement between maybe the host and the virus. Of course, after millions of deaths, or maybe sometimes generation of people, to have this equilibrium. So that's probably where we are. And definitively, since 2 or 3 weeks, everyone starts to speak about endemic for an infection that should stay like maybe the flu. So we have to be a bit positive also. What we learn and what COVID will help to go, you know, only 2 males were cured for HIV by having the first one, leukemia, second one, Hodgkin, and they had a allotransplant with a CCR5 mutated donor, so compatible and no cofactor, co-receptor of entry for HIV, and officially the 2 are cured. The good news, and that's probably 2 women, so women can self-cure where men need allotransplant. So 2 women officially, and that was announced this morning by the International AIDS Society, that cures themselves by just doing nothing. So their immune system was able, as an elite controller, to control the virus, and it used to be called functional cure, but in some rare person, functional cure can lead to cure eradication. Officially, many groups, many different doctors from different countries try to search the virus. And the last one, the Esperanza from Argentina, Annal of Internal Medicine last week, officially she is cured. So opening up that immune system on its own can lead in rare case to not just a blocking of a functional cure, but eradication cure just by the immune system and not the terrible allotransplant. So that's re-stimulate, refuel research, and drug companies are since 1 week interested to go back to HIV cure. And this morning, did summer first, I wake up at 4 a.m. this morning to prepare this talk with new data and not cut and paste forever presentation. There is a new strategy. 2 Canadians are co-authors on this paper, Dr. Chaumont and Bluma Broom from Vancouver, showing the new strategy and a new way in the context that immune control of slow progressor can drive to totally eradication cure. So as a conclusion and to keep the time, I think for the 1990, everything was damaged, not too bad in our countries, but still we have to engage patients and to follow science and not to follow crazy fake news. Totally HIV treatment and care were under the shadow of COVID. So it's time to learn and to benefit at least from the COVID. So maybe telemedicine for certain visits to continue, and also the development of HIV RNA vaccine that's ongoing, and early data in monkeys for HIV RNA vaccine are very encouraging. Of course, socioeconomic and stigmatization for COVID, for HIV is still bad. And you know, the WHO say don't block airport when a country acknowledge a new variant, because other country will shut up and not signal new variant to avoid an economical breakdown. So now we have at a crossroad where maybe it's better to tolerate variant and to pay attention than to block everything, because more death by poverty and social war may occur, and then countries may not disclose a new variant. So COVID is likely to stay as an endemic form. We need to study long-term immunity and not just antibodies. Anti-inflammatory help, monoclonal antibody can be used, antiviral started in both our countries. Maybe we need combination strategy, of course. Big factor is human behavior, health belief. One of my nurses resigned because we fight. He was an anti-vax and he found a job outside the hospital, and the crisis was relieved, but it was a catastrophe for me the last month. And for prevention, definitively vaccine is not enough for COVID. We need a toolkit like HIV, so the combination of strategy, which is boring, and we probably starting from endemic to epidemic to endemic. And as Mark said, come this summer to Montreal, re-engage and follow science. That's the theme of the meeting due to COVID. And you can see that the new Sharon Lewin, who is also a leader in HIV eradication and published the Esperanza cases, will be the president, and me, the local chair for local issue. So thank you and welcome to Montreal this summer under the COVID restriction, and be vaccinated with good vaccine at least 3 times. Thank you.
Thank you, Jean-Pierre. A very thorough lecture, a lot of things to learn. We have time for a very short answer. One comment was about, would this prove that HIV self-test or STI self-test time has come?
Yeah, absolutely. With Nikita Pai at McGill, with a leader in self-testing in developing country and in Canada. And we published a review in Lancet last week on that. Definitively, the self-testing, the commitment is very important. But when you tested, you need to be linked to care. So if you have a positive test and you wait, like in Canada, 2 months to have an appointment, doesn't work either. So we need to self-test and to be linkage to care and to maintain and to invest in a clinician, in nurses, in a medical infrastructure, which is important, but self-testing will be important. And today for Canada, you will be tested at the airport when you arrive, as it was done 6 months ago. So you have to test even if you're vaccinated when you take the plane in the country. And when you arrive, you will be quarantined, tested, and you come out from home just when you have the result, maybe the day after. So the world is changing dramatically. And I plan to go to Switzerland to see my daughter, and probably I cannot go because we have to be quarantined 10 days in Switzerland due to the Omicron variant. So I'm quite not very happy.
Thank you. And there's a question about the regular blood work for HIV patients. Do we have data to show that less frequent can be as good as more regular blood?
Yeah, there is data from Africa, at least if you do viral load, and when CD4 are above 200, you don't need to do CD4 anymore. And follow up every 6 months for, of course, people you know and are compliant. And we did that during the COVID, and the good patient in a way remain good with the good 1 pill a day, so easy therapy, and that works well. And of course, if the problem is, if there is something, they should be able to contact us easily. And sometime in a hospital, you have a automatic machine, and it's very hard to find a human being to have a fast appointment and a fast blood test, because even blood tests should be on appointment. So we need also to improve the low follow-up, low frequent, but if there is an event, the easy contact back with the clinic or the physician. And this part is still lacking, at least in our hospital.
That's all the time we had, Jean-Pierre. I think we could have a very long chat. So thank you very much. I would like to acknowledge that this presentation was made possible through a grant from Vive Healthcare. It was unconditional, and we're very happy that of this lecture. And some people are asking, this lecture was recorded and will be available through IUSTI Canada website. You can look in the chat section. There's the website address. There's also the announcement of the following webinars. We hope to have monthly webinars in 2022 like we had in 2021. So that's all the time. So thank you for your participation. I hope you have a good holiday season, and looking forward to seeing you back for the webinars in 2022. Thank you, Jean-Pierre, and special thanks to Greg Penny, who organized the logistic and the invitation for the webinars.